Thank you so much for watching this presentation. My name is Ashley Hall, and I'm a trumpet soloist, music educator, and career coach. I'm on the trumpet faculty at the Longy School of Music of Bard College and manage the career coaching program, helping music students align their musical lives with their values.
And I'm Nathaniel Ty, a trumpet player and pediatric anesthesiologist. I studied at the Eastman School of Music and Boston University and currently practice as an attending pediatric anesthesiologist at Boston Children's Hospital. I also serve as instructor of anesthesia at Harvard Medical School.
So when Nate and I met 14 years ago, I was on my own journey of figuring out how to play the trumpet more efficiently and with more ease. If you're curious about this part of my story, you can hear more on the recorded masterclass that I gave at the National Trumpet Competition in 2019. In short, I moved to Boston in 2005 to completely overhaul my approach to trumpet playing. I studied with Steve Emery, who helped me to debunk some of the myths that I had learned about the mechanics of breathing. I met Nate during my time and noticed a level of ease and efficiency in his music making that I hoped for in my own. And over the past 13 years, we have been on this journey together to learn and understand the anatomy and physiology of breathing and how that can make us more consistent and efficient trumpeters.
Now, when I started medical school, I had no intention of continuing my life in music. As I learned about the human body during medical school, I began to uncover information that was relevant to Ashley's playing. And as we worked together, we began to understand better the strengths and limitations of common approaches to trumpet pedagogy. What you'll hear today is a synthesis of what we've learned from medical and scientific literature, coupled with some suggestions for practical applications of this knowledge. Core to our approach is a belief that we need to use a common and specific language to describe what we are doing. We also believe that the lack of such a language in our discourse as a community has led to misunderstandings and disagreements between students of prominent teachers or schools of trumpet playing. For the purposes of this talk, we will be leaning heavily on scientific terminology, as these terms have specific definitions and are used in a uniform way across the literature. But don't fret, we'll define these terms as we go along.
Before we go any further, it's important to acknowledge the work of Arnold Jacobs. Many of our teachers were fortunate to learn directly from him. Jacobs was both a phenomenal tuba player and a diligent student of respiratory physiology, and his teaching resulted in quantum leaps for many who learned from him. He grasped and applied the fundamental principle that underlies this talk, that using the body's natural way of breathing to power brass instruments allows us to be both efficient and consistent as we grow in expertise. He used many scientific instruments in his own teaching, but always used them to allow students to understand and feel what their body already did naturally. We hope that this talk will help you better understand what your body does all day, every day, and allow you to leverage your already significant expertise in breathing to become a more efficient and consistent musician. So let's get started. First, we're going to start with the anatomy of our respiratory system.
First off, it's important to note that neither Ashley nor I receive any money or support from corporations or companies with relation to this work on respiratory mechanics. Just to plot a course for where we're going, we're going to start today with the relevant anatomy, so the different structures that make up the respiratory system and how they relate to one another. We're also going to talk about the mechanics of respiration, which is the movements that occur of those structures when we breathe, and talk a little bit about spirometry and lung volumes, which are medical descriptions of the different volumes of the lung that we use every day, and specifically how they relate to passive and forced expiration, which is a key part of what we do on the trumpet. We'll also talk a little bit about what's known about the physiology of tone production on the trumpet and some suggestions for how to apply this information. So from a large-scale perspective, there are really two body cavities that are relevant to respiration. There's the thoracic cavity, here in purple, and the abdominopelvic cavity, which you'll see in pink and green on this diagram. These two cavities are separated by the diaphragm, which in most people is about 2 to 3 millimeters thick, that forms a separation between the thorax and the abdomen. This becomes relevant as we start talking about the pressures in these two different areas, as they're often dependent on one another. So the bones of the thorax form the support structure for the internal organs and are an integral part of the mechanics of respiration, as we'll see. So what you see here in the front is the sternum in red. In blue, there are costal cartilages, and then you can see the 12 pairs of ribs as we turn around here to the back. There are joints here between the ribs and the spinal column that allow the ribs to move up and down. And likewise, the costal cartilages form the anterior joint of the ribs that facilitates that same motion. The intercostal muscles exist between the ribs, and they serve two different functions. The external intercostal muscles, because of the way that they're shaped, lift the ribs upward and assist us in inspiration. The internal and innermost intercostal muscles, which mostly are on the back and inside of the ribs, actually pull the ribs together, and what they do is assist in forced expiration. In order to see where the diaphragm is, we have to rotate the thoracic cage up like this, and as if we're looking up from the patient's feet, to see exactly where it lies. The diaphragm is a dome-shaped muscle that aids us with inspiration, and as you can see, there's primarily two components. There's a fibrous band in the middle called the central tendon, and then the muscle itself is around the outside and helps flatten that dome out, which displaces the abdominal contents downward and lowers the pressure inside the thoracic cavity while raising it in the abdominal cavity. Now the lungs hold the air that we breathe in and out, and they sit in the thorax right about here. They also do the main work of gas exchange, which means exchanging gases from the air with those in the bloodstream. We each have two lungs, and one on the left and one on the right. And you'll notice some subtle differences between the two. In the left lung, there's an upper lobe and a lower lobe in brown and blue, respectively. And on the right, there's a middle lobe, which is here in pink. There's also the trachea, which is our main windpipe that you'll see there in the center that carries air to the lungs. Now, this picture makes the lungs look awfully solid, when in reality, if we were to take a piece of the lung and put it under a microscope, this is what it would look like. It's mostly air. The white portion is air. The pink and blue are the actual lung tissue itself. And if we zoom in a little bit, what you'll see is that most of the lung is no more than a couple cell layers thick, and one cell layer thick in a lot of places. Now, that means that there's not much structure to the lung themselves, and they can't hold themselves open. And this is why the lungs will largely collapse if they're not held open by the rib cage. The wall of the abdomen is made up of several different groups of muscles. This is the rectus abdominis muscles, or six-pack many are familiar with. And also we have the internal oblique muscles, as well as the external oblique muscles. There's also a third layer called the transversus abdominis that's not shown here. As we start to rotate around to the back, there are several muscle groups that are present here that help form portions of the abdominal wall. There's the quadratus lumborum muscle, which you see here, as well as the erector spinae complex of muscles that lie along the spine itself and help us with our posture. They also form a fibrous band that helps form part of the abdominal wall. The bony pelvis forms a ring at the bottom of the abdominal and pelvic cavities that helps support not only our ability to walk, but also forms the bottom of the abdominal pelvic space. At the base of the pelvis, there's a muscular layer that forms the pelvic floor. These muscles can also be recruited as part of forced expiration, as we'll see later. Now let's explore a little bit together how these structures move in concert to allow us to breathe. This is a bucket from our local hardware store, and what this is going to show us is exactly how the ribs move. Now picture your ribs with the sternum here in the front and the vertebral column back here in the back. This handle is like one of your ribs, so you can think of 12 pairs of these moving in concert on one side and then on the other. As we breathe in, the intercostal muscles lift the bucket handle up, and then as we breathe out, it settles back down again. And the settling back down is most often governed by gravity, unless we're using an active expiration technique. Now the sternum itself also moves, and if you look from the side, imagine that this piece of this brush here is the sternum, and when you breathe in, it comes up like this, and it goes down like that as you breathe out. So this is commonly referred to as the pump handle analogy. So the sternum again moves up like this and down like this. Now I'm going to have Ashley come in and breathe for us so that you can see exactly how this works in a normal person. So what we're going to do is I want you to just put your hand on your sternum and go ahead and take a big deep breath in. Now, if you do this at home, you can also feel it as well as see the way in which your hands act like the pump handle and move out and away from the vertebral column. And if you turn the other way and put your hands on your ribs and take some big deep breaths in, I think you'll see what we mean by the bucket handle concept. Interestingly enough, as Ashley turned, you may have noticed that it looked like her back was bulging out. And that just also has to do with the movement of the ribs as they pivot off of the back of the spinal column. Now that we've talked a little bit about the structures of the respiratory system and how they move together to accomplish the task of breathing, we need to talk about why air moves. Now, air moves because of gradients in pressure. And in particular, it moves from areas of high pressure to areas of low pressure. And pressure is simply a force over a given area. And for example, if you were to take your hand and press it down against a hard surface, that is applying a pressure that's equal to the force you're pushing down with over the area of your hand. If you were to apply the same force with your fingertip, you'd be applying a higher pressure because that force is being distributed over a much smaller area. Now this is absolutely critically important to trumpet playing because we deal in the pressures of our respiratory system, and the pressures of our respiratory system help us move air from the lungs through the trumpet and create vibration. One of the most important concepts in how the air as a gas behaves is Boyle's law. Boyle described this relationship that you see here, where the volume of a given gas or air is proportional to the inverse of its pressure. Put simply, if you have two containers of the same amount of gas, the one with the lower volume has a higher pressure than the one with a higher volume. This becomes particularly important as we talk about how the volume of the chest wall changes to move air in and out. Most of us are familiar with a weather map very similar to this one that shows areas of high pressure and low pressure as a way of illustrating storms and their movement. Likewise, we also intuitively understand that wind flows from the areas of high pressure to the areas of low pressure. Applied to our respiratory system, when the diaphragm contracts and flattens and the external intercostal muscles contract and raise the rib cage, that raises the volume inside the thoracic cavity, which, by Boyle's law, lowers its pressure. This lowering of the pressure below the outside air pressure causes air to rush in. Likewise, when the diaphragm relaxes, as do the external intercostals, it reduces the volume inside the thorax and causes air to rush back out to the environment once again. Put a different way, the pressure inside the chest varies with the volume of air inside the thoracic cavity. In this classic experiment by Ron and colleagues, the test subjects drew in a volume of air using a spirometer and then allowed their respiratory system to relax and measure the pressures. Now the point at the center of the graph, where the pressure is 0, is known as the functional residual capacity, and that is the point at which the expansion of the chest wall and the lungs' inherent desire to collapse are balanced, and therefore the pressure in the chest is zero. If you inhale volumes above that point, the pressure is positive, and below that point, the pressures are negative. The pressures in the chest are not the only pressures that matter, however, for trumpet playing. If you remember the schematic from earlier, the thorax is in purple, and the abdominal pelvic cavity is in pink and green. And if you can imagine the diaphragm flattening as it contracts and pushing the abdominal contents down in order to lower the pressure inside the thorax, you can also see how the pressure inside the abdominal pelvic cavity would rise during that process. If you think of the entire system, thorax, abdomen, and pelvis, as a single cylinder, with the diaphragm indicated by the blue line, you can see how, by raising the blue line inside that cylinder, you'd create a smaller volume in the upper portion of the cylinder and a larger volume in the lower portion of the cylinder, causing an increase in pressure in the upper portion and a decrease in pressure in the lower portion. We see exactly this situation play out in this experiment by Augustoni and Ron, where they measured the pressure inside the abdomen during breathing. Again, the horizontal dotted line in this case represents FRC, where the forces of the respiratory system are in balance. And as you inhale above that, the pressure inside the thorax drops and the pressure inside the abdomen rises. Below this line, you can see both the pressure in the thorax and abdomen rise as the abdomen is used to expel air from the thorax. These pressure and volume relationships are very interesting and helpful, but they're even more helpful when coupled with an understanding of the medical descriptions of lung volumes. Now, this publication from 1846 by John Hutchinson, a British surgeon, described the very first spirometer that Hutchinson had invented, which is a machine for measuring lung volumes. With his new machine, he was able to describe different components of our breath. The most recognizable is what he calls breathing air, which is the amount that we breathe in and out with normal breathing on a day-to-day basis. Also, he does describe the vital capacity, which is the full amount of air, the largest amount that you can take in and out, as well as some subdivisions thereof. Now, this is fairly similar to our modern descriptions of the lung volumes that we use for the diagnosis of disease, which you can see here. The tidal volume is that amount of air that we breathe in and out without even thinking about it that's responsible for the majority of the gas exchange that we do during a day. If you were to take a breath in and then relax and let it come out, you would come to rest at what's called FRC, or functional residual capacity. That's where those forces of the chest wall and the lung and the abdomen are all in balance. If you were to push below that, we all know we can expire some more volume. That's called the expiratory reserve volume. And if you get to that point where those forces are in balance again, FRC, and then inspire until you can't take in any more air, that amount is called your inspiratory capacity, which is where we do the bulk of our work as trumpet players. Now, just to reinforce our learning, Ashley's going to take us through exactly what these different volumes look like in a practical demonstration.
So we just went over a lot of terms. Let's see what these lung volumes actually look like. First, take a big breath in and then relax and let the air come out. You'll notice that your breath naturally comes to rest and stops at a certain point. The amount of air in your lungs when no air is moving is the functional residual capacity, or FRC. At this point, the pressure inside the lungs is equal to the outside air pressure, and the forces of the lung, chest wall, and abdomen are in balance. FRC is the midpoint for all of these volumes that we're going to explore next. So take just a moment and get some comfort with what that feels like. So find FRC again and watch what happens next. You will start to breathe small breaths in and out without conscious control. The volume of air that is moving when you do this is your tidal volume, which serves to satisfy the basic gas exchange functions of the lung. So let's find FRC again. And then take the biggest breath in that we can. The volume of air above FRC to the maximum that we can pull in is the inspiratory capacity. In trumpeting, we spend a lot of time in this part of our lung volume because passive expiration produces air flow. This is a really efficient place to breathe because you are allowing gravity and the natural recoil of the abdominopelvic unit to do much of the work. Now find FRC again. And this time, you're going to push out the air until you can't expel anymore. FRC, now push. This volume of air is our expiratory reserve volume, which can be a useful tool in planning our breathing for a piece of music. If you expel enough air to get to the bottom of your expiratory reserve volume, and then breathe in until you can't breathe in anymore, this volume is called the vital capacity. This is the most common volume that has been emphasized in brass playing to date, and is commonly confused with our total lung capacity. Now, measuring the total lung capacity requires breathing inside of a sealed plexiglass box, as it is the sum of your vital capacity and your reserve volume, or RV, that we can't access for anatomical reasons. This is the amount of air remaining in the lungs after you have forcefully exhaled every bit of air that you can. Now, perhaps you have used an incentive spirometer like this. When properly used, these devices can provide a rough estimate of vital capacity. But just understand that measuring the precise values of other volumes and capacities requires a medical grade spirometer and an accredited pulmonology function lab, as you would find at most medical centers. When patients learn to use these incentive spirometers, they are most commonly used after surgery to help encourage patients to breathe deeply, and they have been shown to reduce pulmonary complications. For what it's worth, don't put too much stock in how big your vital capacity is. It's only one piece of an intricate puzzle that we will be exploring next.
It's perhaps intuitive to realize that there are different factors that determine how big your lungs are. Hutchinson, in his 1846 paper, recognized that height in particular was an important determinant of the vital capacity. And you can see in this rather large data set that he produced of 1,923 patients that the relationship between height and vital capacity is nearly linear, meaning that the taller you are, the larger your vital capacity. Likewise, age contributes significantly to vital capacity. As you can see, from our teenage years into our early 20s, there's an increase in vital capacity by age, and then a steady decline thereafter. For what it's worth, this graph assumes that a person stays the exact same height over this entire time period. We talked before about inspiration and expiration using this diagram. Now, it's important to note that this diagram only shows what's called passive expiration, where the diaphragm and the external intercostals are relaxing and gravity is carrying the ribs downward. This can be very useful when it comes to trumpet playing, as we'll see. Passive expiration involves the relaxation of our respiratory apparatus back to equilibrium at FRC, where those forces are in balance, and it's only possible within the inspiratory capacity. In passive expiration, the intrathoracic pressure and intra-abdominal pressure are positive and then decline until they reach zero at FRC. We can see this illustrated again using our pressure volume diagram from Ron and colleagues in 1946. Here is FRC that we talked about before, and it forms the resting point for our passive expiration. As we take in volume above FRC within the inspiratory capacity marked here, you can see that the pressure inside the thorax becomes positive. And as we relax the thorax, we slide back down that line toward FRC. Likewise, as we look at the abdomen, we are taking air in and increasing the volume of the thorax, which means that we're displacing the abdominal contents downward. Here in the abdominal pressure graph, you can see FRC marked here and the inspiratory capacity above it. Consequently, as we inspire, the pressure in the abdomen goes up, and then as we release it, that recoils back to zero at FRC. Now, passive expiration is very important, especially for efficient trumpet playing. However, it's not the only show in town. Forced or active expiration involves the use of the internal and innermost intercostal muscles, abdominal wall, and pelvic floor. Also, it is very versatile. It can generate high pressures at any lung volume, and both the intrathoracic pressure and intra-abdominal pressures are positive regardless of what the lung volume is. In essence, forced expiration works when passive expiration isn't an option and adds important versatility to what we can do. To illustrate this versatility, this study from Lausted and colleagues is a derivation of some predictive equations for the maximum expiratory pressure able to be produced by an individual by their percentage of their vital capacity. Essentially, they had people take in a proportion of their vital capacity and then give the hardest forced expiration they could. And they produced a set of equations. As you can see, there is some difference with an increase in vital capacity, but very high pressures are possible even with very little volume inside the lung, up to 100 centimeters of water or nearly 10 kilopascals of pressure, at just above the residual volume, which I said was not accessible for anatomic reasons. As we'll see later, these kinds of pressures are more than adequate to produce most anything on the trumpet. In addition to that, this study by Fizz and colleagues shows that not only can we do things with forced expiration, but that trumpet players can actually be trained to have stronger ability to produce a forced expiration. This is a study where they looked at a group of controls, or normal people, and then a group of trumpet players. And if you look at their indices, their lung volumes are fairly similar. However, if you look at the last line where it says PE max, which is the maximum expiratory pressure, the trumpet players could produce far more expiratory pressure than the general population. So for Ashley and I, this raised the question of what we are capable of. So we decided to set up a pretty simple experiment. We used a pressure transducer and measured the pressures of different volumes of the lung, essentially replicating Ron's 1946 experiment, and then adding forced expiration to it. So this is Ashley's pressure tracing from that experiment. She took in a breath to 10% of her inspiratory capacity and relaxed, and it produced just under a kilopascal of pressure. Then we increased it stepwise to 25% of her inspiratory capacity, 50%, 75%, and 100%, as you can see. And, as expected, the amount of pressure she was able to generate increased. Then I had her take 100% of an inspiratory capacity breath and bear down with a strong forced expiration, and you can see she was able to more than double the pressure that she could generate. It's also worthwhile to note that the pressures generated by relaxation, which in this case is a surrogate for passive expiration, are very consistent, and over multiple trials produced very similar results. Compare that to the forced expiration tracing taken at 100 samples per second, and you can see there is significant variation in the pressures produced with a forced expiration as opposed to a passive one. Well, why does this matter? Why do we need to know what kind of pressures we can create with our respiratory systems? Well, for some time now, it's been known that to create a note at a given volume requires a certain intraoral pressure. And the higher a note gets, the more intraoral pressure is required. Likewise, the louder you want to play a given note, the more intraoral pressure you're going to need to generate. And this has been fairly well borne out in the scientific literature. This article by Fletcher and Tarnopolsky in 1999 shows just how this process works. If you look at the far left curve, which is labeled F3, that is a low G on a B-flat trumpet below the staff. And what they did is they had, this is a professional player, attack a note at pianissimo, and then play louder and successively louder up to fortissimo. And as you can see, each successive increase in the sound pressure level correlated with an increase in blowing pressure up to a point. Likewise, the authors document an increase in the blowing pressure required to produce notes that are higher. Freire and colleagues were able to replicate similar results in the experiment that they shared at the 10th French Congress of Acoustics in Lyon, France in 2010, where they showed an increase in intraoral blowing pressure required for increases in volume as well as increases in pitch. They also, however, were able to document some very interesting information regarding the actual flow of air that goes through the instrument with these different conditions. If you look at this data here, they placed a flow sensor in line with the trumpet and were able to directly measure flows that way. Likewise, they were able to place reflective discs on the trumpet player himself around the chest wall, and using technology similar to the motion capture techniques used in Hollywood, were able to calculate the volume of his chest wall and the changes that occurred over time and produce a flow tracing from that. The bottom line here is that the louder a note that you're playing, the greater the flow required to produce it. Likewise, the lower a note that you're playing, the greater flow required to produce that. Now, many people are used to hearing analogies from trumpet teachers saying that to play in the upper register you need faster air, which would imply that the air is flowing at a higher rate. Unfortunately, this experiment suggests that that's simply not true, and that the flow is lower in the upper register than it is in the lower register. Likewise, the flow is higher when you're playing more loudly than when you're playing more softly. Now, the studies that have been done to date on this topic are small, and clearly need to be replicated with larger numbers of trumpet players. However, it's worth noting that the general conclusions of the studies that have been done on this topic to date have all generally agreed with one another. That being said, there's a tremendous amount of work left to be done.
When it comes to applying this information, we are going to focus on one specific example about how varying your lung volume can help you play more efficiently. In order to start a note on the trumpet, a player must coordinate the appropriate intraoral air pressure, facial tension, and mouthpiece force, and have these in equilibrium at a given moment in time. This can be challenging for many players, including those who are experienced. James Thompson elaborated on the work of Shubrick to come up with his approach to attack practice, which utilizes the variation in intrathoracic pressure with lung volume to reliably produce the intraoral pressure required to produce a note. Thompson uses the analogy of the inspiratory capacity as a gas tank and encourages students to only fill the tank far enough to produce the note required. The percentage filling of the gas tank is specific to any given note at any volume. The player is then encouraged to let the respiratory system relax, like an archer releasing an arrow. This passive expiratory approach is very reliable and reproducible precisely because the percentage of the inspiratory capacity image yields a consistent lung volume and thereby a consistent intrathoracic and intraoral pressure. So let's try it. I'm going to play a concert A in the staff, which for me requires a breath of about 40% of my inspiratory capacity. I'm going to first take in approximately 40% and then initiate a passive expiration, which should give me a resonant concert A. Okay, now I'm going to take a 75% inspiratory capacity breath and play the same concert A. What did you notice? To my ear, the concert A was a bit sharp and less resonant. So now let me try a 25% inspiratory capacity breath and play the A again. For me, that sounded like the A was flat and also a little less resonant. I'm able to compensate, of course, with varying degrees of facial tension to produce the same tone, but the tone quality suffers. I can use forced expiration to produce a resonant tone with a lower lung volume, but it requires more coordination and a lot more muscular effort, which uses energy. Trying to produce a resonant tone with a greater than required lung volume requires braking or using the muscles of respiration to lower the intrathoracic pressure by isometric opposition. This also requires more coordination, and it is a large waste of energy when an alternative exists. So let's try another attack. I'm going to now attack a low concert B flat, which typically requires a breath of about 20% of my inspiratory capacity. But for now, I'm going to take in 100% of my inspiratory capacity and let my lips receive the passive expiration. What did you notice? Now again, of course I can use extra muscle coordination to start that low C in a really resonant place with a huge breath, but it's not necessary or efficient. So here it is at 20% inspiratory capacity. Finally, when attacking a note in the upper register, I want to increase my inspiratory capacity to achieve the higher intrathoracic and intraoral pressures needed for that acoustical frequency. So, for a high concert B flat, I'll breathe to around 100% IC and test the attack and see what happens. Okay, so one of the questions that we get a lot is, what happens if we need to start in the lower register and play into the more extreme registers where we might need more intraoral pressures behind the lip? This is where we need to go back to the respiratory anatomy. Active or forced expiration involves the use of the internal and innermost intercostal muscles, abdominal wall, and pelvic floor to raise the pressure in both the abdomen and the thorax. This increased pressure supplies the energy to move out of the body. You can see this type of intra-abdominal engagement when you watch any efficient lead player. Now, I'm not a lead player, but I'll just show you a short demonstration. By taking in a 20% breath for the low C and increasing my facial tension and intraoral pressures through intra-abdominal engagement, I can do things like this. So let's summarize what we've talked about today. First, the science of respiratory mechanics provides a common language for communication in the trumpet world if we will take the time to learn it. Second, we need to differentiate between scientific observation and pedagogically relevant analogy when teaching trumpet pedagogy. Also, remember that your brain does a masterful job coordinating complex movements, so a great analogy can be very powerful. Song and wind still is an effective image for many. Many of the musical tasks that we undertake can be efficiently achieved by starting with measured inspiration and passive expiration. And finally, intraoral pressure, facial tension, and mouthpiece force exist in an equilibrium for a given note at a given volume.
Now, clearly this talk has been based on the work of a lot of people. And we want to take some time to thank a few who haven't gotten specific, explicit mention elsewhere. The first is Dale Olson, who has been an incredible resource as we have undertaken this journey. And in particular, the last line that Ashley mentioned prior to switching to this slide is a concept of Dale's that we haven't specifically acknowledged before this. His equilibrium principle, we think, is fundamentally right based on all the information that we have, and is probably the most complete explanation to date of how the trumpet works. Also want to thank James Thompson, who has been a great teacher over the years for both of us, and has also been very helpful as we've been exploring this topic in particular. Steve Emery and his teaching has been instrumental for both of us at times of injury and difficulty in our own playing, and has been just fantastic to work with and an inspiration for both of us. And Gary Radke, enough can't be said about him. He is a phenomenal mouthpiece maker and one of the most thoughtful people that we've met in the trumpet community about how mouthpieces and trumpets are put together and how they work. Obviously, both of us have had an enormous number of teachers over the years, which would be very difficult to list here, and especially without leaving out some names. And so we just want to take time to thank them as a group, and are very, very grateful to their tutelage between my medical school residency and fellowship training, as well as musical training, as well as Ashley's musical training as well. It's been a lot of people who have gotten us to where we are today, and we really greatly appreciate that. Also, my colleagues and the staff in the anesthesia department at Boston Children's Hospital have been incredible and very supportive of this work, and we're very grateful for that as well, in addition to taking care of a lot of very sick children every single day and doing an incredible job of that. We also want to thank the Longy School of Music, who has given Ashley incredible flexibility to speak and to do her coaching work and really become the fullest version of herself that I have yet seen.
So we know that some of these topics that we've covered today might spark some questions. And so we would love to hear from you. This is our contact information on how to find us, ahall@longy.edu. You can also find me on the web, ashleyhalltrumpet.com, or www.coachingthewholemusician.com. And you can find me also on Facebook.
And if you'd like to get a hold of me, you find my email there. And always happy to hear from anyone about the contents of this talk. We have learned a lot in discussing these ideas with a lot of different people,
and we're still learning.
We're still learning a
So
great
much.
deal about what is out there. So we'd love to hear from you.
Thanks so much.
At the end here, I also did want to leave you with a slide of references in case you're interested in pursuing any of the original source material for this talk in more detail. Thank you so much for spending your day, night, afternoon, whenever it is that you're listening to this talk with us. And I hope that you and yours are staying safe and comfortable during this pandemic time.